Good afternoon, everybody. Welcome to today's webinar on high utilizers of Medi-Cal services, hosted by the California Healthcare Foundation. I am Chris Perrone, Director of Improving Access at the Foundation and moderator of today's webinar. Today's webinar features findings from an analysis of Medi-Cal data. It is part of a series of Medi-Cal data symposia sponsored by the California Healthcare Foundation, the California Department of Healthcare Services, and the UC Davis Institute for Population Health Improvement. The first symposium on maternity care was held last year, and the second on high utilizers of Medi-Cal services was held in March of 2015. Due to the overwhelming interest in the March event, we are hosting today's webinar to give many more people the opportunity to hear and discuss one of the featured presentations. Over 500 people have registered for this webinar, representing a broad cross-section of healthcare organizations, government, advocacy groups, and others. The enormous interest and appetite for the information to be presented today comes as no surprise. The Department of Healthcare Services collects vast amounts of clinical and cost data about the care provided to 12 million people enrolled in Medi-Cal, the nation's largest Medi-Cal program. Aggregating and analyzing this data is key to understanding the Medi-Cal population, identifying opportunities to improve healthcare and outcomes, and managing public spending. And today, more than ever, attention is on high utilizers of health services, both because they are responsible for the lion's share of public and private healthcare spending, and also because of the enormous impact that Medi-Cal policy has on their lives. They, more than others, depend on public coverage to provide access to care to treat their chronic conditions, to provide life-saving specialty care, acute care, and prescription drugs, and for long-term care. We are fortunate to have two terrific speakers today, both leaders in their fields. Jim Watkins is Chief of the Research and Analytics Studies Division of the California Department of Healthcare Services. Jim is responsible for directing and producing official Medi-Cal statistics and performing analytic studies designed to help the department achieve its goals and objectives. Prior to his current position, Jim held several other positions at CHCF, including Chief of the Fiscal Forecasting and Data Management Branch. Jim has worked with Medi-Cal data for more than 21 years, and I can't think of anyone else who knows more about how to use Medi-Cal data effectively and responsibly than Jim. Before and after we hear from Jim, we'll hear from Dr. Ken Kaiser, Distinguished Professor in the UC Davis School of Medicine and the Betty Irene Moore School of Nursing, and the Director of the Institute for Population Health Improvement, the UC Davis Health System. A full summary of Dr. Kaiser's many impressive accomplishments could take the full 90 minutes, so I'll mention just a few. A board-certified physician, he is a member of the Institute of Medicine, the National Academy of Sciences, and a fellow of the National Academy of Public Administration. He was a founding president and CEO of the National Quality Forum and was Undersecretary of Health, where he led the U.S. Department of Veterans Affairs, and a director of the California Department of Health Services. After hearing from Ken and Jim, we will have about 30 minutes for question and answers. Before I turn the microphone over to Ken, I need to do two more things. First, I would like to thank two key partners of the Department of Healthcare Services, whose leadership has made this Medi-Cal Data Symposium series possible. They are Dr. Lynette Scott, Chief Medical Information Officer, and Dr. Neil Kahatsu, Medical Director. I would also like to thank Timmy Leslie and Libby Segarra of Blue Path Consulting and Lauren Vandam and other colleagues here at CHCF who helped organize this event. Second, some housekeeping. This webinar will be recorded and posted to the CHCF website within a week. All participants will be in listen-only mode. Please do not place this call on hold. If you have questions, please type them into the chat box. We'll try to answer as many questions during this webinar as time allows, and we will publish a Q&A following the webinar to try to address additional questions we didn't have time to get to. With over 500 participants, we may need to group some questions, and even so may not be able to answer every question. We are interested in your feedback and learning from our experience today, and with this in mind, we ask that everyone complete a short survey at the end of today's webinar. The survey will pop up as you exit the webinar. With that, we'll get started. Ken, we're handing the mic over to you.
Thank you, Chris, and thank you all for joining us today. I'm hoping that the slides are going to cooperate, which they are not at the moment. But thanks certainly to the California Healthcare Foundation for both sponsoring this webinar and for supporting the work on the Medi-Cal Data Symposium series that you referenced. If I could perhaps get someone to advance the slides. There we go. Maybe now it will work. So let me just start off with some general comments before Jim gets further down into the weeds. And then we'll come back and try to tie things up at the end with some potential implications for what all this means. I would note at the outset that Medi-Cal covers a very diverse population that has quite heterogeneous needs. It operates under a very complex set of both state and federal policies, and this complicates understanding the high utilizers because of the sometimes different policies that govern the different coverage categories. In the current fiscal year, Medi-Cal provides coverage to approaching 12.5 million beneficiaries of diverse types. Today, approximately 1/3 of all Californians are covered by Medi-Cal, and more than half of all children in the state are members of Medi-Cal. The state will spend well over $90 billion this year, a combination of state and federal funds. And if I could have the next slide. The program has materially grown in the last few years. Enrollment since 2011-2012 has increased from 7 million to over 12 million, as I noted. Expenditures have grown more than enrollment, growing from around 43 billion to over 90 billion, although for California, there's been a relatively modest increase in the amount of state general fund expenditures. Those have only increased about 14% versus federal fund expenditures, which have increased well over 130%. As I noted, the Medi-Cal serves a very diverse population, and that is reflected in their needs and what is spent. While the average for all Medi-Cal members, or the spending for all Medi-Cal members in 2011-12 was around $4,200. It ranged from no expenditures for 13% of all enrollees, or 40% of the fee-for-service members, to at least one member who is reported to have cost over $18 million for that care. Next slide. Just a couple of general comments about costs and chronic conditions. As I think everyone appreciates today, the primary business of healthcare is managing chronic conditions. 3/4 of all spending is for chronic conditions, and at least for Medicare, the typical patient has multiple conditions and sees many providers of different types over the course of the year. And as shown on this slide in the graph there, certainly the cost of care increases for each additional chronic condition, going up several fold as the number of chronic conditions increases from 1 to 5. Next slide. Now, Atul Gawande particularly focused attention on the high utilizers, or as he called them, the hot spotters, in a now famous article in the New Yorker back in January of 2011. And for many people, this was perhaps the first time that they became aware of this dynamic. However, the distribution of healthcare expenditures and the concentration in a small percentage of the population is not a new observation. It has been remarkably consistent for the past several decades, as shown in the table here. If we go back to 1970, The amount of expenditures accounted for by the top 1%, top 5% of the population has been remarkably consistent decade after decade, and those numbers remain pretty much the same today as they have been for the past 40-plus years. Next slide. And this gives rise to what I've called the population healthcare expenditure pyramid, in which we can basically divide the population into 5 different tiers according to what percent of the total healthcare spending they account for, with the top 1% of expenditures or the top 1% of the population accounting for around 20 to 25% of total expenditures in a normal population, and the top 5% or 5% of the population accounting for another 25 or 30%, getting us to that roughly 50% of expenditures that was noted before, and going down to where in Tier 1, a relatively large percent of the population, typically about half of the population, accounts for only about 3% of total expenditures. Next slide. And this actually, we can use expenditures as a marker to identify the complex patients and look at them or look at who is in those categories as a way to improve service delivery, to perhaps better address their needs and help better manage utilization and costs. But in doing this, next slide, it's important to point out that high utilizers are not a homogeneous population. They may be medically complex or high utilizers for diverse reasons, and if we're going to appropriately manage their utilization, then we have to understand why they fall into the high utilizer or medically complex category. They may be there because they have a single condition that is not well managed. They may have multiple chronic conditions. They may have suffered a serious calamitous traumatic event. They may have serious congenital or genetic conditions. Mental illness is a consistent feature, and that may be part of a complex array of conditions, or it may be a single cause that accounts for high utilization. Likewise, persons at the extreme edges of the age spectrum also may account for high utilization. And a variety of other reasons, social circumstances certainly, and of course homeless individuals come to mind here. So, next slide. The data that we're going to talk about is part of a larger effort that the department has embarked upon to improve the quality and the better manage the care of its patients. Some of this falls under what's been known as the Medi-Cal Quality Improvement Program that we have been working with the department on. Some of it is just because the department is seeking to better understand how it can provide better services. And I think with that, I'm going to toss the baton to Jim, who's going to walk us through what the analysis of his group has shown as far as the Medi-Cal high-cost populations.
Thank you, Ken. I'm Jim Watkins, the Chief of the Research and Analytics Studies Division here in DHCS, and today I'm going to give you a brief overview, because Medi-Cal is so complex, of Medi-Cal's high-cost populations. We're going to start out with sort of an overview of how Medi-Cal spends its dollar. Then we're going to drill down to a unique population, which are individuals treated with diabetes. Go over a few case studies to bring it down even lower to the ground level. And then we'll talk about some end products that we're close to putting out on our website now that might be helpful for you all. Now, I hope everyone can see my pointer that's on the screen, because it'll be important as we work through this. So in this first slide here, as Ken said and others, there's 12.3 million eligibles in the Medi-Cal program, about a third of the population. A little context here, Medi-Cal enrollment has grown substantially since the ACA implementation. We've also had significant growth, about 1 million members during the recession that started in 2007. We also, the Healthy Families were transitioned. So a number of things have been happening in the Medi-Cal program over time. A couple other things that are happening, as Ken touched on, is the Medi-Cal budget has grown substantially, overall spending to upwards of $90 billion today. Most of that growth has been, as you can see on the slide here, the green section, these are federal dollars, so we've had a substantial increase in federal dollars. Slight increase in state general fund spending, and then the other funds, which can be provider taxes and other sources. Now, I'm highlighting the red circle you see in 2011-12. This is a fiscal year. The estimate was about $43 billion in spending. A couple things here to take from this. The estimate, Medi-Cal's estimate, is based on a cash basis. The presentation that you're going to see is essentially an accrual basis, so these numbers don't reconcile exactly, but it's safe to say we spend a lot of money across here, and you'll see that in the following slides where we're going to break it out into about $38 billion. One more contextual piece that's really important here is during 2010-11 forward, we've had a substantial shift in the number of Medi-Cal beneficiaries participating in managed care. So we're moving away from fee-for-service into managed care. In terms of fee-for-service spending, the high point was in fiscal year 2010-11. So that's essentially why we're picking this year, which is calendar year 2011, so we can get a good sense of the population's needs before this transition into managed care, and look at some of the chronic illnesses through fee-for-service and managed care. But we're going to tie this all together, so we'll have people in managed care as well as fee-for-service. So you can see the trend here, and then we're focusing on this year here, calendar year basis. A couple things about this slide that are important to look at. If you look at the pink here, these are managed care carve-outs, so these are services that we have not delegated to the health plans. And so we pay those through fee-for-service. So those are rising as we move people from the fee-for-service system into managed care, and the fee-for-service dollars are dropping off in terms of people participating in fee-for-service. Now, this slide is very important to the overall presentation, so we'll spend a few minutes on this. So we're looking at calendar year 2011 dates of service. There were 9.2 million individuals who had at least 1 month of eligibility throughout the year, and our total expenditures were $38 billion, almost $39 billion. And we brought this together. This includes both fee-for-service spending as well as managed care. Some things that you're not seeing is certain types of supplemental payments that are paid outside of the claims processing system that you won't see in the total dollars represented, but everything else is in here. We're going to focus today on the left side of this slide, which says eligibles that are eligible for Medi-Cal only. So we've broken the population into two groups, those eligible for Medi-Cal and those who are duly eligible for Medi-Cal and Medicare. The next rung down here is what we've decided to do is split this into 3 different subpopulations. So if we look at the individuals eligible for Medi-Cal only, there were 7.9 million individuals who had at least 1 month of eligibility. We spent $26 billion on this group. We have individuals participating in fee-for-service throughout 2011. That is, they didn't switch into managed care. Their entire time was spent in the fee-for-service Medi-Cal system. There were 2.5 million. Spending was $8.9 billion. The next group we have are individuals participating in fee-for-service and managed care. So these are individuals throughout the year that maybe spent 6 months in managed care and 6 months in fee-for-service. We had 1.6 million individuals, and we spent $6.6 billion. And then the final group are individuals participating in managed care their entire enrollment period during 2011. And we had 3.6 million, and we spent $10.5 billion on this group. So our the way we're going to proceed through this presentation is we're going to focus on this purple group first, and we're going to show the cost distribution among this subpopulation, the types of conditions and diseases. Then we'll drop down to the fee-for-service, those participating in fee-for-service and managed care, and those participating in managed care only. And one thing that you'll see is there's a lot of commonality here in terms of both the cost distribution and the types of conditions that are driving the cost. So the first slide here that I want to go over to is what data sources did we use and how are we getting this information? So if we were to sort of look at these circles here and start out in a clockwise fashion, we have the Medi-Cal eligibility data, and this is an important piece here. It's the denominator for many of the statistics that you'll see presented later in the report. And going clockwise, we have Medi-Cal claims, which are the fee-for-service claims, provider seeking payment, plus the encounter claims from the managed care, as well as the capitation maternity supplemental payments. Short Doyle, mental health, DDS, in-home support services, dental, that whole claim set is brought in as well. Drug and alcohol programs, Medicare claims eligibility, including the chronic condition warehouse parts A, B, and D. Now in this presentation today, we're not focusing on the duals, but if you go to our website, you'll see extensive work around the duals where this data set is used extensively. The other is the OSHPD patient discharge data. So on the inpatient side, we're using that for both the PQIs, inpatient days, and inpatient utilization. So we can see it across both fee-for-service as well as people in managed care. The OSHPD ED data sets, vital records from public health, includes birth and death files. And then the next one is the ARC chronic condition indicator, which is an algorithm, and we create data sets that allows us to identify people who have a chronic condition. It's just a dichotomous indicator, 101 meaning you have a chronic condition. It also counts the number of chronic conditions that a person may be dealing with. And then the ARC clinical classification, which essentially takes the ICD-9s and groups them into a smaller subset of classifications for analysis. And then the final thing is we risk adjusted the entire Medi-Cal population using both the ACC risk adjuster from CMS as well as the CDPS risk scores. And you'll see some of this later on for individuals. So the first is we're going to start out with the $26 billion in spending, and we had three groups. And so if we remember, on the left-hand side of the taxonomy slide, we're focusing on the 7.9 million individuals that were eligible for Medi-Cal only and participated in both fee-for-service and managed care. So our three groups, we have individuals who participated in fee-for-service only in 2011, and you'll see the spending here is simply fee-for-service payments. That's the blue, $7.1 billion. And the purple is the $1.7 billion. Those are things like mental health, in-home support services, DDS, CHDP, and dental services. The middle are individuals who participated both in fee-for-service and managed care. And it has the most mixed payment structure. So while they were in fee-for-service, you'll see the blue at the bottom. That was $2.4 billion, and the next up is the $571 million, which are carve-outs associated with their time enrolled in managed care. The green $2 billion are capitation payments. When they are enrolled in managed care, the department paid a capitation. And then back to the purple, which is $1.5 billion associated with mental health and in-home support services and other services. And then finally, to the right, we have individuals who participated in managed care throughout the period, their enrollment period. And what you'll see here is the biggest component are the capitation payments, $7.1 billion, followed by $1.4 billion, which is the red in the bottom, which are carve-out. And then the purple at the top is the mental health services. So in terms of cost distribution, as Ken alluded to and talked about specifically, this is not a new concept. You can see here the spending is concentrated among a small group of individuals. So the top 1% of the individuals generated almost 30%, 27% of the spending. $7.1 billion on the aggregate, and had a per member per month cost of $8,105. The top 5% accounted for 51% of spending, and the top 10% was 6 out of 10 dollars, or 63%, were associated, $16 billion. So, and then the bottom 50%, which is important here, very little spending. The aggregate spending there was $2.3 billion, $75 per member per month, and accounted for about 8.9% of the spending associated with the 7.9 million people who were eligible for Medi-Cal only. In terms of eligibility pathway, which is important, so one of the things that we wanted to look at here is, are there certain characteristics with the different populations that are eligible for the Medi-Cal program, and how do they relate to the top 1%, 5%, and 10%? So as Ken talked about, Medi-Cal is a very diverse population. We have foster children, long-term care, we got the undocumented, the blind and disabled, and so many conditions, people simply are uninsurable risk and they come to our program. So if we look at this chart on the far left-hand side, we say all fee-for-service, managed care, and managed care, the three populations, about 63% of those are family, and that makes sense because that's the biggest portion of our population. And the largest eligibility pathway coming in. But as we move to the right, what we'll see is the blind and disabled are major subsets within the top 1% and 5%. So for instance, in the top 1%, 71% of that group are blind and disabled. So their eligibility pathway, they came into our program in many cases with some type of disabling condition. Similarly, in the top 5%, 66% were blind and disabled, and the top 10%, almost 6 out of 10. So, and probably no surprises here again. In terms of types of conditions, and so one of the things we did here is we compared and contrast the most costly 5% with the least costly 95% of the population. And one of the things that comes out in all of these drill downs in the data is mental health conditions, substance use, and even homelessness. We have some indicators for that. But as you'll see here, any mental health among the top 5%, almost 60% of them were treated for some type of mental health condition, whereas the least costly 95%, only 9%. Serious mental health was 45% among the top 5%, only 5% among the bottom 95%. And as you move down, if you can see the pointer here, there are certain conditions, too, that are only present among the most costly 5%, and there are conditions that you would expect to see. Utilization. So if we look at utilization, a lot of times among high-cost populations or hotspotting, and what you see in the literature is this focus on ED use. And so one of the things you'll see here, using the OSHPA data and matching these two data sets, is that we can see the most costly 1% have an extremely high ED use rate per 1,000 member months. So it's 143 per 1,000 member months. Medi-Cal overall is 35 per 1,000 member months. And then the least costly you'll see down here is 23 per 1,000 member months. What we don't show here, but that's important and at some point we'll present, is when we look among the homeless, some of these rates are as high as 300, 400, and 500. So much higher based on certain living conditions that we can sort of get markers out of the data to identify. The other side of it is inpatient utilization, which is commonly looked at among the high-cost utilizers. And so here what we're presenting is the inpatient acute days per 1,000 member months, and then the average length of stay. And so what you can see is if we start with the all fee-for-service managed care, fee-for-service and managed care, which is the entire population, 7.9 million that we're looking at, and the $26 billion in spending, the average length of stay for hospital doubles as we move up the cost cohort. So the most costly 1% had an average length of stay of 9.1 days. and had inpatient days per 1,000 member months of 115. Overall, Medi-Cal's average length of stay was 4.5, and the inpatient days per 1,000 member months was only 7.2. So these patterns show up over and over in the data as you work through. Now, and remembering too that one of the largest cost drivers is hospital inpatient, you begin to really see what's driving the cost as we work through this. So the next is Ken touched on this with his figure where he was looking at the number of chronic conditions, and we looked at the number of body conditions and then per capita costs. And so one of the things that you see here, certainly if you have no chronic conditions, you have a per capita cost is $873 for fee-for-service participants, and then for those that participated either in fee-for-service or managed care, or fee-for-service and managed care, was $1,326. But with 10 or more body conditions, you can obviously see it's $113,000. You know, if you drop down to 3 or more, or 3 body systems, it's about $13,000. So certainly this increases as the number of body systems and chronic conditions are present among these subpopulations. So now we're going to switch to those participating in fee-for-service only. So we just looked at overall fee-for-service and managed care, now fee-for-service only. And so we have a slightly different cost distribution here. So you can see this is more skewed. The top 1% accounted for 35% of fee-for-service spending. So 25,000 individuals incurred $3.2 billion in aggregate spending and had an average cost per member per month of $11,480. The top 5% accounted for 70% of spending, and the top 10% was 84%. Now, the bottom 50% here was less than 1% of spending. Now, an important point here to see is that 40% of the people who participated in fee-for-service throughout 2011 did not have a health care service. So that explains this $1 per member per month cost associated with the bottom 50%. Spending in terms of these subpopulations, so again, we're looking at the $8.9 billion. Again, these are the people on the left-hand side of the taxonomy participating in fee-for-service only. And you'll see among all eligibles, about 29% of the spending was associated with inpatient hospital services. And then as we move to the least costly, 90%, which I think is important, you'll see this big jump in the green category. This is hospital outpatient, physician, clinic, all the outpatient services, and this makes sense for this lower cost population. And then what you see as you move to the most costly 10%, and the green shrinks, inpatient rises, and the other thing that comes into play is nursing home, in-home support services, health home, and also developmentally disabled. And that's very consistent when we move to the most costly 1%. Again, nursing home, in-home support services, and inpatient. So very high cost categories here driving the cost among the highest cost cohorts within the population. In terms of age, it's what you'd expect to see. So if we look at the individuals 45 to 64, and incidentally, when we look into our data, the incidence of mental illness treatment among that population is quite high. Also, a number of homeless within that subpopulation. So again, if we look at all fee-for-service, Medi-Cal only, we can see that individuals aged 45 to 64 represented 11% of the population. But in terms of the top 1%, that same age group represented 43%, and among the top 5%, it represented 38%. And again, among the top 10%, it was 31%. Again, if we look at children, it flips the other way. So children 1 to 12, among fee-for-service Medi-Cal eligible only, they represented 22% of the population. But among the top 1%, they were only 9%, and among the top 5%, they were 10%. So it's sort of what you'd expect to see among these subpopulations, although we have some unique populations among, for instance, the children and some foster care children that fall into these high groups that we won't have time to get into here, but if we were to drill down, we could explain these further. There's some unique populations. The other thing that, that you should take note of here, that you won't see a number of the aged here because we're excluding the dual eligibles out of these, this population or this analysis. Otherwise, these distributions would be slightly different. Again, you'll see the same pattern here. So remember, these are fee-for-service, Medi-Cal eligible only. You'll see that the dominating population, the blind and disabled, again, 7 out of 10 of the top 1% are categorized as blind and disabled, as well as the top 5% at 63%, and top 10% it's 48%. Again, some of the categories like long-term care you see here, the distribution is slightly different because the duals aren't in here. If we brought the duals in, more of them are dually eligible, so the distributions would be slightly different. But this focus here is mostly on the blind and disabled. Again, here's the types of conditions. Remember, we're looking at fee-for-service, Medi-Cal only again, and we're comparing and contrasting the top 5% to the least costly 95%. And what you see is the dominating role mental health plays in terms of these subpopulations. So among the top 5%, 55% were treated for any mental health, and serious mental health was 42%. And of course, some of the things that you'll see always in these subsets are hypertension, diabetes, mood disorders, and of course, developmental disabilities among this group. And then similarly down with HIV and some of the coagulation, dementia tend to be in the higher cost groups in almost every case. Spending is one thing that we looked at as aggregate spending by these conditions. Note that the conditions represented here, these aren't mutually exclusive. Someone could be in multiple ones, but if we were to take our data set, capture everyone that was treated or had a condition for a serious mental illness, and aggregated all their dollars, Medi-Cal spends about $3.3 billion alone on this group. Similarly, people with hypertension and diabetes, you can see $2 billion. And then maternity and maternity care, so certain infant complications certainly are high, so and we account for 50% of the births, so it's no surprise that aggregate spending there would be extremely high. The other way to look at this is we could look at per capita costs by certain conditions as well. So we may have some conditions where there's only a few, but they have very, very high per capita costs. Hemophilia, some of the other conditions, we may only have, say, 600 individuals identified, but have very, very high per capita costs. In other cases, we have a low per capita cost for some subpopulations, but a number of people that are, infant and maternity care, for example, would be one of those categories. So again, ED visits, similar pattern here that we saw before. So the Medi-Cal's overall rate among the fee-for-service is 37 per 1,000 member months, and the ED rate rises among the top 1% to 151 per 1,000 months. Very, very high among those top cost cohorts. Similarly, the inpatient utilization, you'll see the same thing. So these are inpatient acute days per 1,000 member months, much higher among the top 1,000 or the top 1% than Medi-Cal's overall rate. So among the fee-for-service, it's 1,610 per 1,000 member months, and among all participating fee-for-service eligibles, it's only 65 days per 1,000 member months. And you also see the same pattern among the average length of stay. So the average length of stay is much higher among the most costly cohorts, like the 1%, than it is among Medi-Cal overall, or those that are in the lower cost cohorts. One thing that we wanted to do here that we added since the last presentation is this notion of persistence of high costs across the population. So as you're thinking about interventions and other ways to look at these subpopulations, it's important to differentiate someone who had an acute event and is a high-cost individual for 1 year, but then drops off into the next year into the lower-cost cohorts. So we looked at 2005 through 2010. So we identified the most costly individuals in 2005, and you'll see it here. It's the blue line, 100%. And then we track them through 2010. And so what you'll see here is in 2006, for example, 54% of the original cohort continued to be members of the most costly 10% of Medi-Cal's population. Other things happened too along the way. So we had some people who were deceased, some people enrolled in managed care, and some people became dually eligible, and you'll see this green thing over time. So there's a 2-year waiting period, so some people are moving toward from Medicaid to Medicare coverage, and so that will lessen their cost on our side. And so you'll see in 2007, 50% of the individuals were still in the most costly 10%, and then by 2010, it's still close to 30% of these original individuals were members of the most costly 10%. This is the same chart, but looking at the most costly 5%. So again, if we take the subpopulation, 2005, we track them over time. By 2010, 22% are still members of the most costly 5% of Medi-Cal's population. And then one thing we want to look at is what is our spending over time. So again, looking at those top 5% from the period 2005 through 2010, you can see we started with 155,000. By 2010, we had 34,000. Over this period, we spent $15.9 billion on this group of individuals that are tracking through the system. And as you'd expect, their per capita cost was rising as well over this time. I think it was close to 10.7% compound annual growth rate over this period. So there's a substantial amount of spend on the group, and they're consistently occupying these high-cost cohorts within the Medi-Cal population. Now we're going to turn to the fee-for-service and managed care population, just show you the distribution and the similarities. So remember, these are individuals who participated in both fee-for-service and also managed care throughout the year. And as you'll see here, we have the same cost distribution, concentrated, small number of individuals driving significant proportion of the overall spending. The top 1% accounted for 23% of total spending. The top 5% accounted for 50%, and then the top 10%, 63%. And then the flip side of this, so you'll see slightly higher spending than fee-for-service overall per member per month, which was $98. The bottom 50% accounted for 10.8% of the spending. The next one we're going to turn to is those participating in managed care only. So these are individuals that were in managed care for their entire year. And so you'll see here a different cost distribution, and some of this has to do with how we pay for the capitation. But remember, in capitation, one thing that we do is we do some risk adjusting, and then we also pay for carve-out services, and then we also have services that simply aren't part of the capitation actually during these years, certain mental health services and in-home support services and short dole. But you'll see here, similar cost distribution. Top 1% accounted for almost 20% of spending, top 5% accounted for 34%, and top 10% accounted for 44%. The bottom, or least costly 50%, accounted for 24% of spending and accumulated $144 per member per month cost. Now we're going to drill down, and I'll go through this quickly so we don't run out of time here, but what we did here is we focused on fee-for-service eligibles treated for diabetes during 2011. There was 100,680. So here's what we're looking at. We started with the $26 billion that you saw that in the early taxonomy slide, 7.9 million individuals. We're going to identify individuals treated for diabetes that were 18 or above. We spent $3.6 billion on this population. There was 303,000 eligibles, and we're going to focus on this piece of the pie right here, this slice, the purple, the 100,680, which accounted for almost $2 billion in spending in the fee-for-service program. You'll see the cost distribution again, no matter which population we pull out. This is slightly less skewed in the sense that the top 1% accounted for 12.8% of spending. The top 5%, 35%, and the top 10% accounted for 52% of spending, and then the least costly accounted for 8.6% of the spending. Some characteristics that we can look at. So if we look at individuals treated for diabetes and compare them to the most costly 5% or all beneficiaries overall, you'll see blind and disabled certainly was the dominant population here, about 7 out of 10. So 70% of the most costly, 71% of the most costly 1%. Similarly, you'll see long-term care as you move into the most costly cohorts among this population. It tends to be certainly an eligibility pathway. Fewer families, so you don't see families among the highest cost. So they may have diabetes, but they're not in the highest cost cohorts within the 100,000. Age groups, you'll see 21 to 64, since we've censored the data some, so it's the dominant age group here. 65 and above, you'd be dually eligible, so you're not well represented here. Now, there is some interesting distributions in terms of subpopulations by race, ethnicity when we're looking at the diabetic patients. So the African American would tend to be members of the top 5% and top 1%, but when we look at the overall diabetic population, they're only 8% of the population, but they're 16% of the top 5%, and they're 19% of the top 1%. Later on, as we work through this, you'll see some of the statistics that that relate to these subpopulations. Utilization, ED user rate per 1,000 member months, you'll see overall for the population was 93 per 1,000 member months, which is much higher than Medi-Cal's 35 overall. But among the top 5% most costly, the ED rate per 1,000 member months rises to 220. The most costly 1%, it's 248. Similarly, the inpatient days per 1,000 member months, 348 among all the diabetic patients, 100,000, but it rises rapidly to 2,700 among the top 5%, and the top 1%, it's 5,200. So significant differences within these cost cohorts. These are some of the types of conditions treated, and comparing contrasting the most costly 5% with the least costly 95%. You'll see hypertension on the top, differences 71% for the most costly 5% were treated for hypertension, but only 40% for the least costly 95%. Serious mental illness, again, you'll see is the dominating role here, 53% of the most costly 5%, but only 20% among the least costly 95%. The other one that's interesting here in some of our data, and if we look at the OSHPD inpatient, is pneumonia, which is prevalent among this population and accounts for a number of inpatient stays and complications, and we see this again in the data as well. Looking at the inpatient days per 1,000 member months, one of the things that we did is we looked at the entire 100,680 individuals who participated in fee-for-service and were treated for diabetes, and we broke the population into 4 groups: those with diabetes only, those with diabetes and serious mental illness but no alcohol and drug, those with diabetes, alcohol and drug, and no SMI, and those with diabetes, serious mental illness, and alcohol and drug. And as you can see here, as you add each of these comorbidities to the subpopulations, both inpatient days per 1,000 member months and ED visits per 1,000 member months rise significantly over time. So if we look at inpatient days per 1,000 member months, for those with diabetes only, they had an inpatient days per 1,000 member months rate of 296. Those with diabetes, serious mental illness, and alcohol and drug and substance abuse, that rate rises to 795 days per 1,000 member months. Similarly, when we look at the ED rate per 1,000 member months, we see diabetes only 62 ED visits per 1,000 member months. But if we add in diabetes, SMI, and alcohol and drug, we see that it rises to 469 visits per 1,000 member months. In terms of spending, it's what you would expect here. Inpatient is a significant driver of overall cost here. So if we look at people with just diabetes, The per member per month cost is $1,459. That's over here. If we look at people with diabetes, SMI, and alcohol and drug, it rises to $3,743. As you can see, among two populations, diabetes, alcohol and drug with no SMI, and diabetes, SMI, and alcohol and drug, significant drivers are inpatient hospital services. The per member per month is over $1,000 per member per month. When you add the SMI, pharmaceutical, as you'd expect for the different psychotropic drugs, increases substantially. And then the other side of it is in-home support services starts rising as you add some of these other conditions over time. And finally, this is sort of a case study. So we've seen this high-level view of the Medi-Cal population, how we spend the money. But what we tried to do here is give you sort of a picture of who are the individuals and what do they look like. So we've sort of made up some pieces here based on the data, the underlying data, to give you a sense. So the first one we'll call Mr. B. It's a male, 26 years old, disabled was the eligibility pathway. Health system was fee-for-service. They participated. They had indications of homelessness. We have a variable that we've designed for that. They were members of the most costly 1%. Medi-Cal spending during 2011 was $116,000. Acute inpatient was significant here, $67,000. Physician claims, well, there were 103 physician claims, 112 pharmacy claims. They interacted with the short Doyle system. ED visits, 23 ED visits. Hospital stays, 23. Hospital days, 36. Average length of stay, 1.6. Preventable hospitalization, so looking at, say, PQI-90, the composite measure for the preventive quality indicators, 18 of those fell into that category. And they had a CDPS risk score of 6.28. And if we look at the clinical classification, they had 4 body systems impacted. And they were dealing with a number of issues: alcohol and drug dependency, back disorders, congestive heart failure, developmental disability, diabetes, and hypertension. So a number of things were happening. Similarly, if we pick any one of these categories, we see a similar picture. And so when you get into the top 5 and 1%, some variables that were key here as we looked at the data was the CDPS risk score, as well as the indications of homelessness, which among some of these populations was a significant driver of both ED use, inpatient stays, and medical transportation. It was not uncommon to find people who had 200 transports throughout the year. And so in mental health is the other side of this that you'll see. It's very common among these subpopulations. You almost can't find anyone within the most costly groups that hasn't been treated for some type of mental illness. And so with that, I'd like to just end on a note here in terms of what RASD will be doing over the next couple of months. So one of the things that we're going to be putting out are a couple of reports. One is the preventable hospitalizations among Medi-Cal's diverse populations. So we've got an extensive report that we're going to put out. We're going to have 2 years of data looking at these measures across the Medi-Cal populations. We're going to look at the Medi-Cal's undocumented population as well, those without satisfactory immigration status. We're looking at about a 5-year period that we've created a report here looking at utilization statistics, demographic profiles, and costs over time. The third report is overview of Medi-Cal's alien population. So we're looking at both qualified and non-qualified populations. They account for about 1.9 million individuals in the Medi-Cal population. And then we're finishing up our annual rebirth report again that will be online. And then the role of federally qualified health centers in Medi-Cal population, which is, I think, is a very interesting report that will be out here very soon. And then 2 reports that are ready to go, and we're close to putting them out. We took the CHIS data and we looked at Medi-Cal's child population, so children 0 to 11, and those 12 to 17. And we looked at a bunch of both demographic factors as well as socioeconomic issues around these subpopulations. And the impetus for this report was our work around the PQI. So we want to try to understand the social economics and those factors associated with some of these statistics and how to understand them in the context of the Medi-Cal population. And then finally, we have our Medi-Cal Monthly Eligible Trend Report. So if you haven't seen that, you should go to our website, and it goes out each month. And thank you all. With that, I'll turn it over.
Great, thanks, Jim. This is Chris Brown with the California Healthcare Foundation back on. And before we hand things back to Dr. Kaiser, we're going to take a few clarifying questions directed at you, Jim, on the presentation. And let me start with this. You presented spending on duals, and the question are the amounts shown for spending Medi-Cal expenditures only, or did they also include Medicare spending?
Yes, they would be Medi-Cal only, but remember in this presentation, so if we go back to the original taxonomy, I can't cursor up to it, but anyway, we're working on the $26 billion spend. Actually, if you can turn this thing back to me, I'll move up a slide to where it's at, and it'll be easier to explain this.
Okay,
so
we're doing that.
Okay, great. So if we go back, just to give you a sense here, that's an important question. So if we're looking at this slide here, we were discussing this whole area here, 7.9 million individuals with $26 billion spend. These are individuals who are eligible for Medi-Cal only, does not include duals. So what you just saw, this is excluded. This is not included.
Right, and in terms of the right-hand grouping where you are presenting the duals, just those numbers, the spending number that you show there, is that Medi-Cal? That's
yes.
Just the spending by Medi-Cal?
Yes.
Right.
So when you see these numbers here, this is the Medi-Cal spend, and if you want to see the combined spend, which is 2010, it's actually on our website. And so you'll see both.
Thank you.
Yep.
Okay, great. Second is some of your charts that show the different eligibility groups for Medi-Cal include spending for undocumented. And the question is, which undocumented groups does Medi-Cal cover? And I can help answer that if you want to take that one.
Sure. So there's about 6 different groups that we identify in the data. So if we think about the broadest definition at the federal level, which are aliens, and we have both qualified and those who are non-qualified. So the undocumented that you're seeing here are the non-qualified without satisfactory immigration status and do not include PRU-calls. So they are entitled to emergency and pregnancy-related services only.
Okay. And so those who are undocumented that receive full scope Medi-Cal are categorized in another group?
Yes, so those would be categorized because they have an eligibility pathway the same as anyone else into the program, and we assigned an aid code. So if you were disabled, you'd get a disabled aid code. So, and when you say undocked too, so if you're talking about non-qualified aliens, the only ones that would be undocked that would get full scope would be those in PRU-call.
Okay. And then, but folks like green card holders and refugees and certain others are also categorized by their eligibility pathway, not into the undocumented group.
Precisely. In fact, we have an alien paper coming out here in the next couple of weeks that'll actually go over that, that's a good question that'll address a lot of those, and you'll see each of the subpopulations.
Great. I hope we answered that for the person who submitted the question. And then the last clarifying question, and we did receive some other questions, but I'll hold them until after Ken's presentation. The last clarifying question is, you had said in your presentation that many high-cost individuals have uninsurable risk. What did you mean by that?
So one of the things that we've been looking at in a lot of the work that we're doing on this side is, and many individuals who come to our program, say with a pre-existing condition, and much of this relates to prior to the ACA, but if you think of, say, breast and cervical cancer treatment, for example, you could come to us with stage 4 cancer, and we will insure you in our program, and no other insurance company would take you. So when we look at the data and we look at outcome measures and other statistics, one of the things that we really have to keep in mind and bring in context is these subpopulations. How do we call them out and then identify them to make sense of the measures? So, for instance, when you're looking at PQIs, it's very different among some of these subpopulations who come to us late in their illness or come to us because of an accident in the retro period.
Okay, and so has that changed now? I mean, this is older data, but with the Affordable Care Act and the rules and the insurance reform rules in place, one might expect some of that to change.
Yeah, I mean, that's one thing that we were predicting, thinking that there would be some change. We simply don't have enough data yet, but for instance, people in the retro period, 3 months prior to their application date, looking at their rate for PQIs versus others, it's very high, and we have assumed that some of that will change through the ACA and Covered California. So I agree with you, Chris, that should happen.
Okay, great. We're receiving more questions, but I think at this point we'll take those at the end. We've got some time for another presentation with Dr. Kaiser. And Ken, are you on the line?
I am. So I just want to perhaps wrap this up with some general comments. I would note that there is a lot more detail that has been generated, and what Jim presented here was in many ways a distillation of a lot of additional data. A couple general points I would make is, one, that the Medi-Cal data is generally consistent with national Medicaid data. There's a few wrinkles that may be slightly different, but by and large it's consistent. And it's also, if we were to look at a population that is perhaps socioeconomically and in other ways relatively comparable to Medi-Cal, the VA-covered population, it's generally consistent with what has been identified among VA users. Donna Zulman and Todd Wagner and others at the Palo Alto VA have published several papers in the last couple of years in this regard. And with the exception of neonatal care and congenital conditions and some other things, the data are generally comparable to what we see in Medi-Cal as well. I think as far as what can you do with this data, I think if nothing else, it underscores the importance of understanding high utilizers when you think about what you might do to change those utilization and spending patterns. Certainly at the top of the list is the role that mental health conditions play as a major driver of high utilization and the need to build mental health capacity. It's going to be very hard to do much for these high utilizers if our mental health care system and our capacity for treating mental health care or providing mental health care is not increased. It's clear that inpatient use is many times higher among the top 5%, and the average length of stay is longer, which kind of underscores the need to minimize hospitalization. And that, of course, depends on the specific reason for the hospitalization and of the subpopulations, what might be the potential interventions for reducing inpatient stays. And the same applies for emergency department use, since, as Jim pointed out, it is several times higher, certainly for the top 5% and even higher for the top 1%. And again, the need to look for and put in place alternatives to emergency department utilization. I think an important point, which, as Jim noted, we didn't have as much information on a couple of months ago when these data were presented at the symposium, was on the persistence of high utilization over years. And as was pointed out, among the top 5%, more than 30% of those are going to remain high cost, or in that top 5% for 4 consecutive years, and over 20% for more than 6 years, which we looked at, and again, underscoring the need for ongoing intense care management. And some of those, while they moved out of the Medi-Cal population, just moved into a different coverage category. Their needs didn't change, but they just became the responsibility of a different payer, Medicare in particular. If I have the next slide. And the last couple observations is, as was noted, the low utilizers do add material cost to Medi-Cal, and at the moment there's relatively little data that demonstrates what the value add is for enrolling them, and there is a need for better data in this regard. And as the one who pioneered Medi-Cal managed care in the 1980s, certainly the belief has always been that managed care would produce better outcomes, but when we actually look for data, it's not as available as one might like to have. And then we didn't get into, in any significant way, the fact that there are some Medi-Cal policies that actually effectively preclude being able to reduce utilization. And some of the categories, just, if you can only provide coverage once you're an inpatient and you can't provide the outpatient care that might prevent that, it's very hard to do anything about reducing that utilization. So there is a need to identify and change some of the policy barriers that effectively preclude reducing or appropriately reducing utilization. Jim, I don't know if you want to add anything to that last point. If not, we can turn it open to questions. Chris?
Okay, thank you. Jim, did you have anything to add to that last point?
Yeah, actually, I think that's an important point that you'll see in the PQI paper that we're working on, and working some with Ken, looking at different benefit coverage in the Medi-Cal program. So if you look at, for instance, preventive quality indicators and ambulatory care sensitive conditions among Medi-Cal's undocumented, they don't have access, for example, to primary care. So it's emergency and pregnancy-related services only. So the changing the network that you deliver care to these people won't change it without a change in the benefit structure.
Great, thanks. So we've got a few more questions that have come in, and still terrific participation among attendees. Before I go back to the questions, I just want to remind folks that the webinar is being recorded, and we will post a video recording on the website in a week, along with the slides from today's webinar. Slides from the March Symposia event, which included much of this material, as well as several other presentations, is already available on the CHCF website, so you can get that immediately. Along with the video recording and the slides from today's webinar, we will also post a Q&A that includes the questions that we are responding to here, as well as any of those we don't get to. So I think, Jim, most of these questions are for you. Any sense of what share of those people that are categorized as disabled, blind or disabled, are people whose disability is a mental health condition? We do have those numbers. I don't know the top of my head, but again, when you look at the subpopulation, if you're looking among the top 5% of the most costly or the top 1%, it's well over half, 60–70%. It's much higher. So
certainly that's something that we can put out there and create a slide. Mental health combined with any of these chronic health conditions, I think Ken has touched on it, and the literature is filled with it. It is the significant driver for these individuals.
Yeah. Well, and I think if I can guess that part of the thrust of the question from the attendee is that in some cases, high-cost conditions are a way into the Medi-Cal program, and so that's why, particularly among people with disabilities, we see such a high share of them accounting for the highest cost population.
Yeah, and that's exactly, and that's what I was getting at also with the uninsurable risk and some of the other issues. So when we look at some of these populations, we're the sort of the insurer of last resort in many cases. So people come to us with complex medical conditions, and so when you use some of these outcome measures and statistics, you have to build context to really understand what it means. So simply comparing it to the insured population, for instance, in many cases doesn't make a lot of sense.
Right, thanks. In your categorization of the comparisons of the full population and the top 1% where you listed the different diagnostic categories, you separated out schizophrenia and mood disorders from the SMI category. Was there a reason that they're not all included together?
Yeah, so for instance, schizophrenia and SMI are really within there, but for some work that you don't see here, for example, looking at individuals who are homeless who are dealing with schizophrenia, for example. So we wanted to be able to identify each of those unique subpopulations. So they have very different characteristics, as you can guess, in how they both utilize services and sort of the health outcomes in the data set that you see.
Yeah, okay, great. This is a question that you both may want to take on, but maybe we'll start with Jim. How do you anticipate the distribution of these costs changing in post-expansion, so beginning in 2014?
Well, I mean, just technically from an actuarial sense, which is my bad, I don't see the distribution changing significantly. If you look at the work from Burke and Monheit, and if you're talking about the cost distribution, even with the implementation of managed care, and Ken showed this in his slides, the distribution among the top 1%, 5%, hasn't changed in decades. In fact, if we grab any subpopulation in here, you'll see a similar distribution with slightly more or less skewing. So if we pick everyone with diabetes, slightly less skewing than, say, children if we pull them out of the subpopulation. But overall, a small number of people generate the bulk of the cost.
Yeah. Ken, did you want to add anything to that, or is that?
Yeah, well, a couple points I would. One is that I don't see it, the distribution materially changing across the board. I think depending on the payer, the distribution may be different. And that may be the essence of it, is, and why you really need to understand your particular population, either that you're providing care for or that you're providing coverage for, is that the numbers will stay the same, but who composes or is responsible for those numbers may be somewhat different according to populations.
And as a follow-up to that, I think an important point, Ken touched on this too, is when we track a cohort of beneficiaries over time who are among the most costly 5% or 10%, remember in our population, we have people who are moving toward becoming duly eligible for Medicare. So what happens is, as a payer, our costs go down, but the health needs associated with that particular individual have not changed. And in many cases, we've bifurcated the system at that point, and it gets harder to manage those patients.
So, and from a provider point of view in that regard, you may still have the patient, it's just the payer changes, but their needs and what you need to do for them is going to remain the same.
Right. So I guess a similar question, and I'm guessing the answer is the same, so you can simply say so if you think. But with the emergence of a number of high-cost specialty drugs the latest for Hep C, but many more in the pipeline as latest report from Avalier shows. Do you expect that to change the distribution at all?
Well, I think it depends on, you have to look at the drugs. So, for example, some of the high-cost drugs for schizophrenia in years past, the drug was expensive, so it increased the pharmaceutical spend, but it was also effective in keeping people out of the hospital, and so inpatient stays decreased, and the net was a lower cost. So it really depends on the specific drugs and the populations in which they're used. And I guess, it underscores the need for why these things need to be tracked in real time.
Great, thank you. Jim, moving on to the next question. How did you identify this indicator of whether or not a person was likely to be homeless?
Yeah, so there's a couple things that we do there. So we have sort of a housing insecurity variable that we've built with the Medi-Cal eligibility data set. So in some cases, what you'll have is your payments from the social services or the county, for example, will go to the county's mailbox, or you will have a file on the an address on the Medi-Cal eligibility file that says under, for instance, the I Street Bridge, or you're moving every 3 months on the file. So what we do is we have a pretty extensive algorithm that we go through, and we identify people on the file based on those characteristics. And then based on those, we run statistics on the subpopulations and look at those underlying populations, and what you see among those subpopulations for housing insecurity or homeless: high mental health prevalence, high ED use, a number of ambulance services throughout the year. As I said earlier, sometimes over 200 transports throughout the year, a number of different types of injuries and skin infections, and so it's quite a unique population. Among that 100,680 diabetics, there was about 1,600 within that group who were housing insecure, and they had an ED rate per 100 of 338. And so, and again, a lot of transports to and from the ED.
And a follow-up question that I don't recall whether it was in your slides or not is what % of Medi-Cal beneficiaries are homeless or came up with this indicator of homelessness?
So in the state, there's any estimates from, say, 117,000 or so, if you look at it at a certain time. With our indicator, it's about 70,000 in the data set.
Great, thanks. So now going up much higher level in terms of the question, while this is a webinar really focused on the analysis of the data, I think there's a lot of questions that revolve around this. Okay, so what do we do with this information? How is it being used? How is it being shared with plans? So I'll ask the broad question, but I also want to recognize that there's probably a lot of you probably have a lot of colleagues there at DHCS who are working to address some of the problems and what you find. But the question was, what policy actions might DHCS take on this information? Does it plan to share this data with plans or providers, or is it sharing this data with plans and providers?
Yeah, I mean, I think all of this is shared, and you can see some of this in our 1115 waiver, where we're talking about housing for the beneficiaries, and the quality work that Neil, the medical director, is doing around high-cost patients, working with some counties that we're trying to pursue some interventions to see if we can identify different subpopulations. So it's continually being utilized throughout the department as we, change the program, and also, think about the waiver going forward. Health homes is another example. We're currently using this same type of analysis to look at patients who may be appropriate or eligibles who may be appropriate for health homes.
Great.
Let me
Ken,
offer
did you want to add there?
Yeah, I would perhaps add a couple of things. And one, just repeating what was already said about that there are some subpopulations for which there are barriers, and we need to be looking at potentially changing the barriers so that utilization could be more appropriately and effectively managed. I think the other one that, or two or three other things. One is that the need to build mental health capacity goes beyond Medi-Cal, and there's a big public policy question there that we need to be doing more to increase our ability to deal with mental health conditions, and there's shortages of people, there's shortages of resources, and there's a broad public policy question here about what are we going to do to build that capacity so that these needs can be better addressed. I think from the individual provider point of view that these data should also indicate the need for doing data analytics and understanding the population that you serve so you can start to effectively address these needs in ways that obviously historically haven't been met, and not just for Medi-Cal patients, but for other high utilizers as well, whether that's through patient-centered medical homes or more home care or more telehealth. I mean, there are multiple different potential interventions that have to some degree already been demonstrated to be effective, and others that are being studied. But to know which ones to pursue, you really have to understand the specifics of the population that you're taking care of.
Great. Thanks, Ken. So, Jim, a few questions here about ways of sort of breaking down the analysis both by provider type and geographically. And the question is that work that you've done, you're doing, do you have any intention of publishing that kind of data that takes a look at the spending by provider type, or takes a look at variation in spending or in the distribution at the county level?
Yeah, actually, all of the above. One of the things that we're working on right now is sort of a geographic analysis and using some mapping software on our end, looking at everything from mental illness within certain communities, ED rates, medical transport, some fascinating information that will come out soon actually on that topic. And then looking across different systems as well. So people that say are in managed care versus those that are in fee-for-service, those that are in the retroactive period as you transition from one system to the next is another area that we're looking at as well. And some of that you'll see too on the PQI measure report that we'll be putting out soon, sort of looking at it geographically as well as unique subpopulations within Medi-Cal. And then we have another report, just as we ended on there, that sort of looks at FQHCs and their patient population and who they treat in some of these rural areas.
Thanks, Jim. The questions keep coming in. Along the lines of this notion that you've been using this data to design a number of different policy interventions and programs, and you mentioned several. And a lot of this, I think, confirms either other data we've seen from other states, other sources. Ken alluded to that as well. What did you find, or what did you and your colleagues find that was particularly interesting or enlightening from this data? Were there any aha moments, or was it more sort of just putting numbers to things that were kind of already understood, but you were just able to quantify?
Well, I mean, I think there are some things that we know sort of going into it, but the dominance certainly of mental illness, and when you look at, say, the top 1%, top 5%, and even if you're not looking in a long-term care setting, the impact of homelessness and some of the social economic factors that really drive it. I think that's the biggest thing that we're getting out of this. You know, again, I go back to thinking about when we really analyze this data and look at PQIs, those events are primarily driven by people that were retroactively eligible for the program or in the SPD categories, not the family, not the undoc. And so for years we've talked about reforming the system to change based on this measure, but in many cases we're probably looking in the wrong direction. So the literature is out there, but understanding our populations, and something important that Ken alluded to is the benefit structure. And, you know, if you're, a breast and cervical cancer treatment program, you come to us many times late in the program. Before June of 2011, we could sell insurance policies in the state of California that didn't cover labor and delivery. So you came to us in a presumptive pregnancy aid code, right? So, and you came late, so you didn't necessarily get prenatal care. So understanding that in the context of so most of these measures are designed for commercial populations, and we talk about them as if they were. But in this case, we've got a unique benefit structure, unique timing of coverage, certain types of coverages that we provide. In some cases, we only provide you with coverage for your specific condition or disease. In other cases, we just award you limited scope, meaning only emergency. So I think that's the biggest eye-opener for us, is to say, let's take, we take some of these off-the-shelf measures or metrics, but then we have to really think about the Medi-Cal context. What does it mean? And so I think that's the major takeaway. Yeah, we see it in this, the other literature, and it's not surprising, but how do we interpret it? Or duals as well is another example. So when you have dual eligible people or someone in an 8 code 60 SSI disabled, and they transition from Medi-Cal coverage only into Medicare after 2 years, what does that mean?
Let me add a little different slant to it. Chris?
Perfect. Yep.
I think one of the things that the data I think makes clear is a need for new models of care. The numbers have been remarkably consistent for several decades, and this should lead one to conclude that doing the same old thing that we've done before may not have much impact, regardless of changing 8 codes and doing some other things, and that we really have to use the tools, the new tools that modern information and communication technology allow us to really design new models of care that may be more effective for dealing with these high utilizer populations. And it's just not going to be doing the same thing that we've been doing for the last 50 years.
Yeah, and one thing I'd like to follow up on that, I think is important that Ken brought up too, is when we look at the top 1% and 5%, it's very heterogeneous. I mean, we have groups with schizophrenia who are homeless. We've got individuals that are hemophiliacs. So you've got all of these different groups, and so designing a program is somewhat complex, and you really have to think about all these different subpopulations, and Ken's health pyramid that he showed is really important, because I took that and applied it to the 100,680 people with diabetes, and I ended up with a group, say, in the middle, were moderately costly, much higher overall than Medi-Cal, but didn't have any mental illness, and there was a substantial group, about 30% of the population. They had different needs, different intervention than, say, the top 1% within that group, which 7 or 8 out of 10 of those had serious mental illness. So I think looking at this data, we have to think of that, too, that context, and how you design around those subpopulations.
Well, and I think just to that point, if you look specifically at the diabetes and the groups that had alcohol and drug problems, that clearly is a major driver, even more so than serious mental illness. And again, you don't have to be terribly clairvoyant to figure out that if you're going to deal with the needs of the high-cost diabetics, you're going to have some programs that deal with alcohol and drug use.
Great. Well, thank you both. Those are very thoughtful responses to a very complex issue, and clearly we could spend at least 90 minutes just talking about some of those issues and new models of care, and clearly there's lots of work ongoing to address that very issue, both in the context of the waiver, the Medi-Cal waiver that's under review by CMS now, as well, and many other related discussions. We're at that bewitching hour. I do want to thank, first of all, Jim and Ken for your very thoughtful presentations and your responses to the Q&A. I want to thank the nearly 400 participants that joined today's webinar, including the 300 of you that have stayed on through the duration. Really terrific participation, and I think it really reflects both the hunger, appetite, interest in this kind of data. I think people are, my sense is, really excited to see this kind of data analysis emerging from the Department of Healthcare Services. I think we all understand that it's been ongoing, but to see it available publicly, I think is something that we all have an appetite for. So really appreciative and encouraging of the work by the department for doing that. With that, I'm going to close things up and just remind everyone again that we are posting the materials on our website, and please do fill out this very short evaluation that will pop up when you exit the webinar. With that, thanks everyone and have a good afternoon.